Okay. All right. Well, welcome everyone to the fifth installment of the Aptitude 2020 series. Excited to have this today. In fact, I was going to start off with, we were recently, this series was recently recognized as an award finalist in the digital communication category for an industry award. So we're very excited after only 4 episodes being nominated for that. But we're looking forward, and we're excited to have this forum recognized for the value it's bringing to the industry and also our customers. Before we get to today's agenda and our speakers from PDI, wanted to give you just a quick background or introduction of Aptitude. For those of you who are not aware, we're celebrating 5 years in the market. Really starting from working with a handful of organizations in 2013 to today supporting the supply chain efforts of thousands of hospitals across the country as they contract for millions of different products. The idea behind Aptitude was to help modernize, in a way, if you will, aspects of the healthcare supply chain, and it's really done primarily leveraging data and technology to manage cost reduction efforts. And all the same, while doing that, reducing the overall cycle time. Other organizations are incorporating Aptitude not as really as a sole strategy, but as a complementary way of helping their team become more efficient. And is providing features at their disposal to help identify, act, and monitor on opportunities. In addition to the platform and the data and technology we have, Aptitude provides resources to help our customers achieve their goals. Today, the scope is really around med-surg, clinical preference, med device, and we're starting to get into lab. Recently launched some categories around vaccine, and we're actively researching both pharmacy and services as a component of the Aptitude model. So that's just always like to give that just a little bit of introduction about what we do, who we are. And so let's get back to the 2020 series, which is a webinar we created to do once a month. As a way of providing a platform to share information on new products and services entering the healthcare supply chain. Today, we're excited to present PDI, who's going to give us an overview of their new nasal decolonization kit, which is preferred by 90% of nurses. So maybe after today, we'll see if we can improve that a little bit. All right? Okay, so let's get going. I'm going to turn this over to Ben, and Ben will let you take it away. You guys on the phone, if you could mute, don't put us on hold, but mute, that would be helpful.
Thanks, Justin. Appreciate it. So let me just switch over to the presentation. Just give me 2 minutes.
Okay.
It seems like we got some music going on in the background. Does anybody hear that?
Try to find out who that is. Hold on.
I like it.
It's a good ambiance.
Yes.
Oh, there we go.
There we go. Perfect.
All right.
All right. So before I start, can you just give me confirmation you can see my screen?
Yes, I can see it.
All right. Perfect. So on behalf of PDI, I think we're very excited to be here today. Vizient Aptitude is one of the really interesting theories that's going to be brought out there, and obviously you guys are very excited to launch the platform. I think today's webinar will be very helpful in giving you a broad overview of our nasal decolonization product and also understanding the market for nasal decolonization. We have a couple of presenters. So Caitlin Stowe is actually, she's our Clinical Science Liaison for PDI. So she'll be going through a little bit about the background and history of why nasal decolonization is important. And then I'll be going through a little bit more on the product side and talking about some of our competitors and how we share up to some of our competitors on the market. So with that, I'll turn it over to Caitlin, who will go through some of the history of nasal decolonization. Caitlin?
Thanks, Ben. Like you said, my name is Caitlin Stowe, and I am a Clinical Science Liaison with PDI. Next slide, please, Ben. Thank you. So today's webinar, we're going to talk about exploring the link between surgical site infections and nasal colonization. We hope that you'll understand the value of nasal decolonization in surgical site infection prevention, and you'll become more familiar with our new product, ProFend, and that nasal decolonization kit and the role it plays in surgical site infection prevention. Next slide. So first off, let's talk about surgical site infections and staph, and specifically MRSA. So SSI by the numbers. So anytime you undergo surgery, you have a risk of developing a surgical site infection. Approximately 2 to 5% of patients undergoing surgery every year get a surgical site infection or an SSI. This accounts of about 290,000 surgical site infections per year, which accounts for about 22% of all healthcare-associated infections, which ties it with ventilator-associated pneumonias as the most common HAI we see every year. 47 to 84% of SSIs actually occur after discharge and therefore are not detected by traditional hospital infection prevention surveillance programs. The associated mortality rate with an SSI is about 3%, so your risk of dying from an SSI is about 3%, and 77% of SSI-associated deaths are directly attributed to the infection itself. So it's a very costly and very serious infection and complication from surgery. Next slide, please. So the most common SSI pathogens, and this is from the data that NHSN gets, you can see there we see some strep, we see some enterococcus, pseudomonas, coagulus, negative staph, E. coli, but by far and large, you see that Staph aureus accounts for about 30% of all pathogens reported in NHSN when an SSI is reported. So if you combine all of the other 5 that are commonly reported, those barely make up the 30% that Staph aureus accounts for. So Staph aureus really is the biggest burden of pathogens when it comes to surgical site infections reported in the United States. Next slide, please. So what is Staph aureus? Staph aureus is a gram-positive cocci. It can be a part of the normal skin flora for most healthy adults. About 15 to 30% of all healthy adults are nasally colonized with Staph aureus. And when you're nasally colonized, that usually just means the bacteria is hanging out, not causing any issues for that person, and it's part of your normal flora living symbiotically with the other bacteria in the nares. However, and then there's 1 to 3% that are actually nasally colonized with MRSA or methicillin-resistant Staph aureus. So they have the drug-resistant strain of the bacteria in their nares. Sometimes you can be colonized in other places other than the nose. Sometimes you can be colonized on your hands, or you can be colonized in the armpit or the groin. But most facilities usually test the nares because that is usually the most common place that people are colonized. Next slide, please. So I like this table because I think it shows a really good example of why staph is one of the leading pathogens and the types of surgeries and where it is more common than others. So for orthopedic type surgeries, it accounts for almost half of the SSIs. So staph causes about 47% of all SSIs reported. For neurological cases, it accounts for about 37% of all SSIs. Cardiac is 30.7%. And then the 2 publicly reported CMS procedure categories, OBGYN and abdominal cases, you have 20% and 12% respectively. Staph accounts for those SSIs as well. So Staph aureus SSIs are a big deal. And what are we doing about them? There's really good evidence out there that shows that Staph aureus nasal colonization can increase your risk of a surgical site infection by almost up to 9 times, depending on the type of surgery that you're undergoing. So it is a big deal, and there's not a lot of facilities doing nasal decolonization currently. And MRSA colonization is associated with worse outcomes and a higher risk for MRSA SSI and SSI overall. Next slide, please. So like I said earlier, SSIs are the most common and most costly healthcare-acquired infection. If you have an SSI with specifically the multi-drug resistant strain of Staph aureus or MRSA, there is a much higher cost associated with that SSI. It does increase your hospital stay from on average from 7 to 11 days. It can cost up to $60,000 per SSI. The average is about $12,000 to $35,000, and personally, I think that is vastly underreported. The total estimated cost per year of surgical site infections is up to $10 billion, and it accounts for about 90,000 readmissions per year, which costs us about $700 million. So, again, very, very costly to healthcare payers. And obviously, CMS reimbursement is at stake. If we're underperforming, especially in those colon and those abdominal hysterectomy cases, and we're not doing well, you have hospital value-based purchasing and your HAC reimbursement at stake as well. So there's a lot of money at stake here if we don't perform well in these cases. So next slide, please. So now Ben is going to take you through. Yep, thank you.
So as Caitlin went through, I think everybody on this phone call can realize the really high costs that these hospitals are seeing because of SSIs. So what I want to go through now is just an overview of the product itself and currently where nasal decolonization is being done in these hospitals and how it can really help reduce these SSI rates and these reimbursement penalties that hospitals are currently seeing. So the first slide, I just want to give you guys an overview of nasal decolonization itself. So up to 60% of SSIs are totally preventable. So there's a lot of different products out there on the market that obviously contribute to reducing SSIs, and we believe nasal decolonization in this product is a great way to basically put together your SSI bundle and help reduce those SSIs for patients. Nasal decolonization is advocated in several association guidelines. So the Society of Thoracic Surgeons, IHI, which is the Institute for Healthcare Improvement, and WHO, which is the World Healthcare Organization, all advocate for the use of nasal decolonization. And more guidelines are actually trying to implement nasal decolonization as part of their guidelines. So you'll be seeing more and more of those guidelines recommend it. The literature out there is very convincing, and as we get this product further into the market, we'll be having some interesting studies that show outcomes as far as reducing SSIs. So keep a lookout for that, but there are currently a lot of societies that are recommending the use of nasal decolonization for pre-op procedures. Also, just as far as the different ways to treat basically the Staph aureus in the nose, there's basically two different types. So you have your topical antibiotics and you have your antiseptics. So the product that I'm about to walk you through is a nasal antiseptic product, and the nasal antibiotic product that's on the market is currently Mupirocin, or the brand name is Bactroban. Also, nasal bacteria can be linked with the skin. So as everybody knows, CLABSIs, a large part of what contributes to having a CLABSI is the accumulation of Staph aureus on the skin, which is why skin antisepsis is important, both pre-op and post-op. And again, like I talked about, I think this is going to be a really important part in putting together an SSI bundle that's effective. So this graph really just shows you exactly where these nasal decolonization products are being used. About 69 performed prior to at least some surgeries. So you can see here there's a lot of potential as far as us getting more and more people or more hospitals and clinicians to adopt this technology, both in the OR, in the pre-op space, and eventually in the ICU, which I'll be talking about. But there's definitely a big footprint out there for a lot of clinicians and hospitals that have bought on to doing nasal decolonization. They're getting really great results. So as I talked about, there's definitely some areas in the hospital where nasal decolonization can be done. Pre-op is one of the largest ones. But this question was proposed as far as whether it was used outside of the pre-op or the OR space, and about 37% of people said it was, and about 63% said no. So again, there's a large opportunity for education to be out there, and we're trying to go out there and educate, obviously, clinicians as far as the impact that nasal decolonization could have in their SSI rates. So some of the areas that I'm going to talk about as far as opportunities for there to be more nasal decolonization, the first one is the ICU. So we've traveled to a lot of critical care meetings and talked to a lot of ICU nurses, and they are starting to do it in the ICU setting. The reason being, a lot of these patients obviously have can actually contract CLABSIs or can have ventilator-associated pneumonia infections. So doing nasal decolonization does help pretty much every infection. So their CLABSI rates and their SSI rates are going to go down if they're doing it in the ICU. Same thing for the cardiac care units. Again, a lot of high-risk patients who are really immunocompromised. doing nasal decolonization in those units can be very helpful. The ER is something interesting there. So a lot of times mupirocin is prescribed to patients and they basically purchase it on their own and they would apply it at home 5 or 6 days before the surgery, about 3 times per day. So the reason that nasal decolonization is being done in the OR is because a lot of these patients are being rushed in and they might go to, the OR for a cardiac procedure or an ortho procedure, and having an antiseptic product readily available is a benefit because you can apply it right at the patient's bedside and get them ready for that surgery. So for a lot of unplanned procedures, the ER is a space that we're looking to expand into. And then other, obviously, so for the general patient population, it's currently being used about 37% of the time. So this is just a high-level overview of the product itself. So the product's name is Profend. The reason it was given that name is because it proactively defends patients against SSIs. The solution that's used in the product is a 10% povidone iodine antiseptic solution. So there's other products in the market that use that solution as well. We'll talk about the different competitor products that are out there. We recently launched the product in March 2018, so we're seeing a lot of facilities be interested in the product, and we're seeing a high adoption rate. It's easy to use, pre-saturated swab sticks that have a snap and swab design. And what that means is, if you're familiar with the other products in the market, like 3M's product, basically what they have is a Q-tip and a vial. And you're supposed to basically dip the Q-tip into the vial. It can become messy. It can drip on the patient's linens or on themselves. So it's not the most pleasant experience. The nice part about this product is it's all pre-saturated, so you don't have to measure out or see if you're getting the right dosage on the Q-tip applicator. And it's just a snap and break off applicator. So you can see on the picture to the right, the top of it you would basically just snap off and it comes right out. The actual end of the product is very small. So if you're working with a patient population or somebody tends to have a smaller nostril, it's easier to get up there. So we've seen a lot of patients be happy about that because some other products in the market, which I'll talk about, have a little bit larger tip, which could be harder to get into the smaller nostrils. And as far as our efficacy, so we have about a 2.7 log reduction or 99.7 efficacy at 10 minutes and 1 hour. And then we're at about 3 log reduction or 99.9 efficacy at about 12 hours. So that's efficacy against Staph aureus. And then as far as broad spectrum, our product does kill other bacteria as well, but Staph aureus is definitely what we're isolating because that's one of the major causes of SSIs. And the main benefit of using an antiseptic over an antibiotic product is the fact that there's no built-up resistance. So a lot of hospitals today are going forward and actually participating in antimicrobial or antibiotic stewardship programs. What that means is they don't want to use any antibiotics where they don't have to because they don't want to see the patients build up a resistance. So this product is well in alignment with those new programs that are being launched. So again, as far as the application time, that's also a benefit. We have a very quick application time compared to our competitors. What there is, you can see the picture to the right-hand side, there's these small patient units, and there's 4 swab sticks per patient unit. What you would do is apply each swab stick for 15 seconds, which is going to be a total of 60 seconds for the entire application. Again, like I talked about, the neat design where you don't have to get your fingers dirty. There's no, the stick itself is not pre-saturated. It's basically just you snap it off and you use it. And again, as far as the compliance portion of it, it does support compliance because patients are happy to use it. They're more comfortable using it. And also clinicians are not going to get messy or stain anything. So the compliance rate is being increased with this product as well. And it is suitable for treating, again, MRSA and Staph aureus in the OR, the ICU, and other areas. So just talking briefly about some other products in the market, just to give you familiar with different competitors. So on the upper right-hand side, you can see Medline's products. So Medline recently bought the Clorox product. It's pre-saturated. Again, like I said, the entire stick is pre-saturated with that dark PVP, so it can get messy on the gloves. It can stain things. So having a pre-saturated applicator is definitely a downside. One of the other parts about that, like I said, is the tip of that actual applicator itself is fairly large. So comfortability for the patients is extremely important. You want to have the patient and also the clinician have a good user experience. Our product is obviously a little bit better as far as having that smaller applicator, so it's more comfortable for the patient themselves. On the bottom right-hand side, you can also see the 3M product. Again, it's a Q-tip and it has a vial. Again, there's dripping. It can become messy. And then you have Nosin, which is an alcohol-based product. So NAS has been putting a lot of effort forward with talking about doing nasal decolonization. The one downside to having an alcohol product is alcohol, as you know from skin sepsis, is a quick kill. So it's going to have quick efficacy, but there's not a lot of residual activity that happens after that. And then on the left-hand side, you can see what I talked about. You have Bactroban, which is the brand name version of mupirocin, and then you have mupirocin, which is just a generic version itself. And we can get into that, but that's basically applied to the patient about 5 days before the surgery, 3 times per day. So it does require that the patient is very compliant when they're actually applying that product. So just an overview of how the packaging works. So again, it's 4 swab sticks per patient unit. Again, there's 12 patient units per shelf, and there's 4 shelf units. So the nice part about this box, it's easy to open. You can actually take the used swab sticks and put them back in the box and discard of it. And the shelf life for our products is all 18 months. So it's okay to be put into kits and things of that sort. The product insert, so there's a couple different ways you can refer to how to apply the product. The main one is going to be on the box itself or the patient unit itself. There's a little IFU on the side that shows pictures of how to use it. And there's also a full product insert in the back of the box. This is just a close-up of the actual images as far as how to break it. Again, it's fairly easy to break, just a back and forth quickly. Will allow you to snap off the actual applicator, and you just pull it out from the vial, and it's ready to use. So again, it's 15 seconds per swab stick, 2 swab sticks per nostril, total of 60 seconds. And I did want to share with you guys this slide because I think it's important. So we did do a patient preference study, and this is what we were talking about earlier. 14 out of 15 clinicians actually preferred this product over the 3M product and the Medline product. And the top reasons were that it was easily administered, it was simple and intuitive, and that compliance would be obviously increased because of this. So the biggest portion we could take away with this is when comparing it to other products in the market, again, clinician experience is important, the comfortability of the patient is important, and you're getting those 2 things with our product compared to some other products on the market. So just in summary, like I talked about, I think nasal decolonization as a market has a lot of room to grow. We're seeing more and more hospitals get interested in using it not only in pre-op areas, but also the ICU settings. And the reason they like this product and the experience that we've seen with clinicians so far is that it's easy to use, has great efficacy against Staph aureus, it has a quick treatment time, so 60 seconds, a neat application, and it supports compliance. So the compliance piece is important, and I think a lot of hospitals are questioning mupirocin for a couple reasons. Obviously, number one, because of the trust you have to put in the patient to go home and apply it themselves, and number 2, because of the antimicrobial stewardship programs that are in place. So that was a brief overview of the product itself. At this point, I'm just going to open the floor to any questions I could help answer.
Great. Thank you, Ben. Yeah, we don't have anything on the chat, but anyone want to ask a question, feel free to do that now. And if you may be on mute, just FYI.
I have a quick question. Is there any evidence in the literature on mupirocin compliance levels in pre-op patients?
Yep, so great question. There is literature out there that shows about a 19% non-compliance with the mupirocin product. And again, the mupirocin product has to be applied about 5 days prior to surgery to be effective, at least twice a day. The actual Bactroban IFU says that actually 3 times a day. And just to give you more context around that, because of the fact that for ER procedures where the patient is coming in, it's not a scheduled case, a lot of times you don't have time to apply an antibiotic product and have it be effective before going into the OR. So I think a big opportunity for this antiseptic product is going to be in the ERs when they're actually seeing patients come in and trying to get them prepped prior to going for surgery. This is going to be a product they can definitely use. But there is literature that shows about a 19% non-compliance rate with mupirocin.
Very nice. Anyone else?
What percentage of the SSIs are caused by Staph aureus?
So right now, literature states that about 80% of SSIs are caused from the patient's own nasal flora. As you know, a lot of times Staph aureus will also live on the skin, which is part of the reason that both skin prep followed by nasal decolonization is important, because the 2 main carriers for Staph aureus are going to be the nasal, the anterior nasal space, and also the patient's own skin. So again, about 80% of the SSIs do come from Staph aureus in the nose.
That's great. Just a quick reminder, we are recording this. It will be available in the next couple of days on the Aptitude website, and we will be communicating about future 2020s and including that link. We'll do maybe one last call for questions, and then we'll wrap up.
Awesome.
Okay, going once. All right, well, great. Ben, thank you so much for doing this today, and everyone on the phone. We appreciate you calling in to learn a little bit more about PDI and what's going on in healthcare. So thank you.
Great. Thanks, guys. Appreciate the time today.
Thank you.